The education of nurses begins with mastery of a large amount of formalized knowledge. Understanding the theoretical rationale for nursing actions is emphasized. Teaching aims to integrate essential content from nursing, physiology, microbiology, biochemistry, and other basic sciences. In actual practice, however, a different kind of knowledge emerges, a knowledge based on experience. We call this kind of knowledge practical or clinical knowledge, a way of knowing through practice. Clinical nursing combines scientific and practical knowledge. In the hospital setting, skillful clinical knowledge is a hallmark of nursing expertise. Therapies are instantaneous and require astute use of clinical judgment by nurses.
The style of physicians' orders has changed from that of precise mandates to guidelines that instruct the nurse to keep the patient within certain physiological parameters, to give the dosage of medications within certain ranges as measured by the patient's responses. This is a shift in instantaneous therapy that really began in intensive care units, but now is widespread in every unit of the hospital. Indeed, the decision on whether or not to hospitalize a patient depends on whether or not the patient requires this kind of nursing clinical judgment about instantaneous therapies, or whether the therapies can be managed at home with less clinical judgment.
Critical care nursing has developed over the last 30 years, such that now we have many nurses who have a great deal of experience in the units, and it's possible to see the expertise that's brought to patient care in those units. There literally would be no intensive care units now were it not for the expertise of nurses in those units, and they're absolutely critical to the quality of care given there. Recognizing this important role of nurses, we embarked on a 4-year study funded by the Helene Fold Health Trust. The purposes of that study were to delineate the practical knowledge embedded in expert nursing practice. Secondly, to identify the nature of skill acquisition in critical care nursing practice. Third, to identify institutional resources and impediments to expert practice. And fourth, to begin to develop educational strategies to better prepare nursing students to eventually become expert clinicians.
This interpretive phenomenological study examined the nature of expert nursing practice and the nature of skill acquisition in 130 critical care nurses in 8 different hospitals. These 130 nurses were asked in small group interviews to give narrative accounts of clinical situations that were memorable to them. In addition to these small group interviews, we also individually interviewed 48 of these nurses and observed them in their actual practice. In the individual interviews, we examined or asked them questions about early nursing experience, their nursing education, and their work history. These data then were type-scripted and analyzed using an interpretive analysis done by the whole research team. This interpretive analysis was then subjected to consensual validation by select nursing participants. We believe that this study demonstrates the power and the expertise embedded in nursing practice, and this video presents some of the results of this research.
We had this patient come into the hospital. He was in liver failure. He was admitted to one of the floors. At the end of the night shift, he wasn't looking very good. He'd started throwing up, and they couldn't handle taking care of him, so they sent him up to us in the ICU.
Colleen, I just got an admission. Would you be able to go out and take it early?
Sure, no problem.
Thanks a lot, I appreciate it.
He was retired. He and his wife had started to travel, and he came down with hepatitis about a year ago. It caused irreversible liver damage. He wasn't in any acute distress when he first came to us. He knew everything that was going on, but his liver enzymes were sky high. I just knew he was sick, but that's the kind of patients that we see in the ICU. Kind of like we would get him over this crisis, and then he would be well enough to go home. It looked like it was going to be a busy day when I got in for report, but by the time I got out of report, he had had a very sudden deterioration. He was alkalotic. He was really working too hard to breathe. So just about then, they started intubating him and setting up to put in invasive lines.
He's doing great.
About 10:30 in the morning, he was being dialyzed. Well, they were trying to put in a central line, but just weren't able to do it after about 5 attempts. We had dopamine and a peripheral line. It was all right. It was a big vein. So all this happened in a space of about 5 hours. It kind of overwhelmed this man, who was really quite with it. I really thought that he would have been more encephalopathic by then, but he wasn't. He was really still with it. I tried to get the family in the room as much as possible. It was good for the family. It was pretty quiet that day. Some of the patients were traveling, and the admission we set up for never came. The family would only come in and stay for a couple of minutes. It seemed that they were pretty overwhelmed. I guess it was the machinery. Really, as the day went on, none of our interventions made any difference in his lab work. It didn't make any difference in his clinical picture. He kept on deteriorating.
Ron, how are you doing?
I was not seeing his eyes the way I had when he first came in. He kept them closed most of the time. He was exhausted, I'm sure, but not seeing his eyes, that's probably what bothered me the most. That really said that things weren't going well. Everything seemed to be happening at once.
Franz, can you come in here, please? I need a 12 lead. Tom, you need to come in here. He's bradycardic.
What's he doing?
I think he's in a second-degree block. Do you want some atropine?
Now, hold off a minute. What's his pressure?
70 over 30.
Yeah, go ahead.
All right.
So we're just
Ron, can you hear me? He's unresponsive.
Have you sent in the labs yet?
Yeah, I sent him a while ago.
Okay, well, I'm gonna go check to see if they're in the computer.
Tom, you need to call the attending. You need to clarify his code status.
Yeah, okay.
His pressure is still 70.
Excuse me. Can you tell me what's happening?
Donna, his heart rate is pretty slow. His blood pressure is low with that, and we're giving him some atropine. We're giving him a drug. He's responded to it a little bit.
He's going to be okay, isn't he?
So far, he's responding to drugs to get his heart rate up. It is worrisome that he's dropped so low.
I see.
Ron, your wife is here.
I'm here, honey. You're going to be okay.
Ron,
You're going to be okay.
I can finish doing this. Go to the secretary, ask for 2 FFP, and bring the
You're going
crash
to be
cart.
okay.
Okay, 2
Thanks.
FFP.
Yeah.
Excuse me, please. For a second.
Daphne, can you help me out in here, please? Can you put him on 100% and get a guess?
Has he had labs sent?
Yeah. All I really need is a blood guess. Everything else was sent before.
Does he need volume?
Yeah, Franz, there's a saline right over there and pressure tubing. Put it on there, please, and get it set up into his left arm.
The docs were really good about talking with the family. The family stood outside the door and they watched everything that was going on. They knew the dialysis didn't really help. Things weren't going well.
This vignette recreates one of the actual clinical episodes told to us by one of our expert nurses. In it, you can see the problem of trying to formalize all of the clinical decision-making done by expert nurses. Here we see the expert nurse clearly has a grasp of the whole situation. She anticipates that there's going to be rapid deterioration with the patient, and she makes all of the arrangements to try to ward that off, or at least to be ready for it should it happen. She coaches the resident through making the appropriate responses. All of this without recourse to analytic problem solving. And this is the problem that I had in my research that I did for about 10 years using an information processing theoretical framework in which one really has to try to formalize all the decision making that expert nurses do, and it's simply not possible. Here, all of this kind of practice escapes the formal models. In 1982, Patricia Benner introduced me to the work of Hubert Dreyfus, professor of philosophy at the University of California, Berkeley, and his brother, Stuart Dreyfus, a mathematician and expert in operations research, also at Berkeley. that helped me understand the limits of formal models in describing expert decision making. My conversations with Patricia about the limits of formal modeling were probably somewhat similar to the conversations that occurred between the Dreyfus brothers many years before that.
Yes, they probably were, and those were similar to conversations that started about 400 BC, and interestingly enough, centered around medicine already, because of Hippocrates, who claimed that medicine had become a science because they now had principles on which to base their care of patients. Socrates became interested in the difference between real knowledge, like doctors claim to have, knowledge held down, as Socrates said, by the rules of cause and effect, rational knowledge, as compared to the kind of knack that people had, cooks and musicians and sports people, who just did what pleased the crowd or what tasted good or what happened to work last time they tried it, which something they picked up by apprenticeship. And Socrates was extremely impressed with the idea that there could be something better than that kind of empirical trial and error know-how. And once he got interested in that, he decided that was real knowledge. So he went around to see if anybody else had real knowledge. And he asked statesmen, and he asked artists, and he asked religious leaders. And what did he ask them? Well, he asked them, what are your principles? Like Hippocrates has, like these doctors have. What are the principles on which you decide what to do? And oddly enough, and to Socrates' horror, none of these people could come up with any principles. They said, well, in this case we do this, and in this case we do that. That's because people have always done this sort of thing in this sort of case, and that sort of thing in that sort of case. So Socrates got pretty depressed about this and decided that nobody had any knowledge. Hippocrates even hadn't come up with these principles he was promising, and Socrates certainly didn't have any. So he concluded, nobody knows anything, and I don't know anything either. And that would have been the end of philosophy right at the beginning if Plato hadn't come along and said, no, that can't be right. If it's true that you've got to have a theory in order to do anything right, then these people who have some kind of behavior that is successful in some domain must have a theory. Maybe they've just forgotten it, that they knew it in some other life. And Plato said, well, they knew it in some other life, but when they got put in their bodies, they forgot it. But it's still there in their minds producing this behavior. So you get the view, starting way back, that any kind of successful action must be based on a theory, conscious or unconscious, that any kind of intuition is just the tip of an iceberg of some unconscious reasoning. In general, then, that any kind of action that could count as knowledge, any successful know-how, must be based on some kind of detached, rational theory.
Well, it's interesting that you mentioned how Socrates put an emphasis on theoretical understanding, because when I first became interested in observing skill acquisition and trying to understand skill acquisition, I was in the very fortunate position of not having ever studied Socrates or knowing what Socrates said. So consequently, I didn't come into my observation of skill acquisition from the point of view that it must be passing from just muddling around and knowing what to do into a theoretical understanding. And what I discovered when I really examined the topic of skill acquisition by thinking about my own skill acquisition processes in driving cars and so forth, and also studying skill acquisition in other areas such as flying airplanes, what I discovered is that beginners begin with a theory are being taught a theory of the domain, and but when they become skilled, they then act on the basis of what you might call know-how. They simply have learned from experience how to respond. They no longer rely on that theory. The theory is important in getting them started, in giving them a chance to have experience, but if one continues to act completely on the basis of analytically thought out theoretical considerations, one never gets really good. So what I discovered in thinking about skill acquisition, or believe I discovered, is that skill moves from a theoretical understanding ultimately to a responding to situations based on experience, doing what worked, without necessarily having a theoretical basis for knowing why it works. So skill acquisition is really characterized by a shift from what you might call rule-based or theory-based behavior to what I call intuitive behavior, namely responding because what you've done in the past has turned out to be good, and therefore you'll do it again. Another aspect of skill acquisition related to this is the change from the analytical perspective, which sees everything as a lot of parts which are then combined in order to reason out what you ought to do, to seeing whole situations. And it's only recognizing the whole situation that defines what the parts are, in fact. So it's a whole-to-part process and not a part-to-whole process. And another aspect, the final aspect of skill acquisition, which seemed to me very important, is beginners tend to see themselves as performing the skill. For instance, a beginning driver sees himself or herself as driving a complicated piece of machinery. But when people become skilled, they become involved in the process of doing what they're doing. They no longer see themselves as driving a car from A to B. They see themselves merely as going from A to B. They and the car, they're so involved with the car in the process of achieving the goal of going from A to B that they don't look down at the car as something complicated. For that reason, it seems, my experience indicates and my observations indicate that when you're really good, and we've seen this in nursing also, action becomes a lot easier than for the beginner because one is involved in the situation, one has an immediate sense of what needs to be done, and one simply does it instead of taking this detached, abstract, theory-driven point of view in which you make a lot of mental effort in order to try to understand the situation and figure out what you ought to do in that situation based on your theory.
Kit Chesla has done extensive work with the advanced beginner level data. Kit, could you highlight some of the findings from that analysis?
Advanced beginners, because of their lack of clinical experience, really have a hard time seeing the whole and rather focus in on pieces of the clinical situation. Aspects of the clinical situation that have been pointed out to them theoretically or by more experienced people are what show up for the clinical beginner. Much of their clinical world is comprised of matching these theoretical categories that they've learned in their formal training with what actually presents itself in the clinical arena. What we've actually learned is that nurses at different levels of skill acquisition actually live in different clinical worlds, and we'll see this as we look at an advanced beginner vignette.
I have a baby with gastroschisis, and that means that they're born with the abdominal contents on the outside. And this problem is managed by putting a special dressing around the abdominal contents called a silo pouch. And they wrap it around until it looks just like a ball with a little twist tie on top. And every day they turn it, once every 12 hours. Well, eventually, all the abdominal contents end up inside, and they leave it like that. Sometimes they go in right away and close it up, and other times they just leave it open. And now they're beginning to think that maybe they should have left it open for a while. Anyway, it's too late now. They closed it up, and now she's starting to have fluid balance and nutrition problems. And the mom starts asking me all these questions, so I told her all that I knew. Hi, Mrs. Yano.
How's your day?
Stable.
How's the dressing?
Now, let's see. See, it looks nice. It's pretty dry.
Can I see what I do?
And,
Is everything okay?
yeah, everything's okay. Bye.
Sandy, you okay over here?
Oh, Anne, I'm glad you're here. This alarm keeps going off, and I don't know what's wrong with it, and I can't really turn it off either.
Okay, well, did you start with the... Oh, Elena, can you come here for just a second?
Well, there are 2 clinical specialists involved right now.
Alarms and how to go through that?
Oh, well, not in a lab, but the mentors would usually set up a pump on a counter somewhere and go through it all.
Great.
Did you check the lines?
All the connections are checked, and it's still alarming.
Did you check the hand? Sometimes it's positional and you can't see anything. Why don't you try that?
Okay.
Good.
Great. Thanks, Elena.
You're welcome.
Anytime.
So that's okay, you understand? But you meant just the position
Yeah.
sometimes helps?
It's the hand.
Okay, so you're okay now?
Yeah.
Good,
I think
okay.
I'm all right.
Great.
Thanks.
The biggest concern is fluid volume. And the reason why it's such a big deal is that her gut is all manipulated. And it's not like you can give a diuretic and have it be okay, because volume excess isn't the problem. It's how she's absorbing it. So I'm watching the monitor for cardiac problems and blood pressure problems and respiratory problems. And it's kind of a vicious thing because they all potentiate each other. I mean, I learned so much, I couldn't even tell you. There's just a lot of things to be done, and just getting those things done, it kind of makes me feel anxious. But it's okay, I can handle it. Except for how the surgical site looks. I don't know about that. The doctor said it looks normal, but who knows? I've got to believe him though, because I don't have any experience with this type of surgery. It makes me nervous. What's really stressful about being a new nurse is the expectation to have that knowledge right now. The patients that I take care of are really critical, and there's a lot going on. You've also got to think of all the things that could possibly go wrong. And at this point, I'm still not real comfortable with that. It's easy to think that you know what's best, but in reality, there's a whole realm of things going on that you don't fully understand. It's like the knowledge should be there, but where is it? And if it is there, it's in your notes, but you still have to read it. You don't really have the time right now to pull out that piece of paper and say, digitalis toxicity, this is the thing that I should look for, these are the things that I should do. You just can't, because it's all happening so fast.
As we have just seen in this prior vignette, the advanced beginner is most concerned with managing the task world. We saw this in the vignette where something came up where the alarm kept sounding for the IV, and the nurse focused exclusively on the alarm to the exclusion of noticing what was going on with the patient and with the patient's mother, who exited the room almost without the beginner noticing or acknowledging her exit. Also of importance for the advanced beginner is detecting and reporting significant changes to people who are more experienced. The advanced beginner doesn't have the experience to know how to manage. They can only notice what has changed and what might be of concern in the change. And they have to have other people enter the situation to help them to cope with that situation. Two additional aspects of advanced beginner practice that we want to highlight are their way of trying to manage the situation according to rules and procedures, and how the situation shows up for them as an instance of learning. The first rule-based practice showed up most clearly when the nurse had difficulty with the infant's IV line and called in experts to help her. And to her, the most important thing to manage in that situation was that she had checked the line, which is, the first thing you would check. It's the rule. But she didn't have the practical knowledge to also check and play with the position of the IV in the baby's hand. The second aspect, how the situation simply shows up for advanced beginners as a situation of learning, came up when the nurse was describing the gastroschisis and how the baby had progressed and all of the things she had learned in the course of the care of this baby. The situation simply shows up as this unfolding learning experience for the advanced beginner, and it's almost a disconnected kind of learning that they have because they do not yet feel fully responsible for managing the situation.
There is stunning growth in the first 2 years of clinical nursing practice. At 2 years, the nurse is typically at the competent stage of the Dreyfus model of skill acquisition and is far better able to handle more complex clinical situations than the advanced beginner.
I had a patient who had had his second heart transplant. I thought I was being a good nurse, turning him every 2 hours, and he really had bad breath sounds on his left side. So I chest PT'd him, elevated his left side so he could drain, and had him cough.
Good. I'm going to take a listen to your lungs.
But it took me a couple of times to realize that when I turned him on his left side with his bad lung down and his good lung up, his pulse oximeter showed great readings and his heart rate was wonderful. But when I turned him on his right side, within a few minutes, he would go into bursts of supraventricular tachycardia and his O2 sats would drop.
And out. please call CTICU 1828, CTICU 1828. Thank you. Hi, this is Molly. I'm calling in regard to patient Sayer. I think he's in an SVT. I just finished doing some chest PT on him and I don't know what's going on. Well,
I had called the doctors and they didn't seem too concerned about it. They said, relax, he has a healthy heart. And I said, if he has a healthy heart, why is he doing this?
I'm going to turn you over to the other side, okay? I want you to help me out here. You're going to let go and just slowly go back on your back. Take your time. That's it. That's it. Slow down. That's it. Good. You're good at this. That's it. I guess the experience helps. Let me help you over here. There you go. Okay, bring your shoulders and hips back to me. That's it. Excellent. I'm going to put a pillow behind your back. Make you comfortable here. There we go. And I want you to lean in slowly toward that pillow. That's it. That's it. Ah, relax. Yeah, good. Oh, good. Your breathing seems to be a lot easier now.
His SVT spontaneously resolved after I turned him off his side. And I said, okay, now I know what's going on. I'll keep him off that side. It was just a hypoxic reaction because he wasn't oxygenating well enough with his bad lung. It could have been a bad situation if we just left this. So now we know that we just have to work on that lung and get it back to aerating again. And he did fine. Kind of humbles you though. At one point, you're feeling like you have things straight now and you can handle this. And then something like this happens and you think, well, I still have a lot of learning to do. I can handle the situations that are status quo. It's the unexpected that I have to deal with now. But then I think back to situations when I was brand new. Things that are status quo now weren't back then. Things I can troubleshoot and solve now were much different then. I usually needed help.
As we've seen from this vignette, the competent nurse can now see relationships among aspects of the situation. They are no longer relying on rules or context-free formulas or recommendations from the textbooks. Her world is structured by the desire to limit the unexpected. They also begin to talk about feeling good when things go really well and feeling horrible when things go poorly. They're not so overwhelmed as they were in the beginning, and they're focused on matching physiological responses to the patient's actual practical activity, which requires a lot of practical know-how. As long as this nurse was focused on the usual formal expectations, well, he has a healthy heart, she could not notice that his response was reasonable, in fact, when linked with his particular lung capacity, an observation that then let her notice and go into a therapeutic action. Another thing that seems to happen at this stage in skill acquisition is what we call the skill of involvement growth. The new nurse primarily talks about exchange and role negotiation and figuring out how to act like a nurse. But early in the second year of practice, the nurse notices the patient and the family suffering in new ways. It is a conscious time of repersonalization of patient and family. The nurse is now more reflective about his or her impact on patient and family. There is a tension between mastering the technology and refining the art and skill of involvement. For this stage in skill acquisition really shows up as a very deliberate choice and an effortful skill that they're working on.
Now this nurse also feels this excessive sense of responsibility and almost acts as if they feel the whole burden of the healthcare team, which is far beyond what any single person could assume, a sense of responsibility. If the nurse only has a vision of mastering the technical aspects of the work, then he or she will never move on to become expert. They have to learn how to use pattern recognition to be able to grasp the whole situation. And if they get stuck in analysis rather than synthesis, they won't ever be able to move on to expert level. The other interesting thing about this level, our data points to this time is a very difficult time developmentally. The nurse may begin to question if he or she has chosen the right career. particularly if they're kind of stuck in this analysis.
Let me tell you a story, sort of my own personal experiences that I think illustrate this dramatic leap and how important it is in acquiring skill. Actually, the story concerns my chess playing ability and really motivated all my interest in this subject of skill acquisition. I basically was asking myself the question, among other things, why did I not get better than I ultimately got in chess, which was pretty good. In fact, I realize now extremely competent, but not proficient. And the situation is this, and you don't need to know anything about chess to really understand this story. I'm sure we've observed the same thing in nursing. I got into chess because I saw it as a very analytical skill, and I was good in mathematics, and so at the age of 10 or 12, I thought, well, one application of this reasoning ability I seem to have been given is to become a chess player. So I learned the rules of chess, and I continued to develop more and more reasoning ability and rules and principles and theory in chess until I got to college. And at that point, I was very good at thinking very hard about and figuring out using a great amount of time and a lot of mental energy, figuring out what I thought was going on in a position and therefore concluding what I ought to do in the position. A lot of my friends who were also serious chess players, like at that stage I was, began to cease to want to play long, serious games of chess in which they thought everything out. They wanted to play fast chess. They wanted to play 5-second-to-move chess. And I rebelled against this. I said, I don't see any reason to waste my time playing 5-second-to-move chess. And my colleagues also began to read the chess games of the grandmaster chess players. And I thought that sounded like a good idea. I should read their games too and find out what it was that they thought about. So I looked at the games, and what I found was the analysis of the games didn't tell me what the grandmasters thought about. It didn't tell me why they made the moves they made. All it told me is what they did, and if they had done something else, what terrible thing would have happened. Another thing I noticed was I lost a lot of times to high school kids who had dropped out of high school and had no analytical ability as far as I could tell. And that also made an extreme impression upon me. So anyway, this combination of things, I realize now is illustrative of the step from competent to proficient, which I was not making and never made in chess, really. And the step is that these players who wanted to play fast, who wanted to just look at grandmaster positions and see what grandmasters did, who could beat me when they were still in high school, were players who were now responding to situations based on pattern recognition kind of abilities. They didn't need to think a long time about situations. They were learning the ability to simply respond. And for them, chess was becoming a lot easier than it was for me. What to me is the most single important aspect of the skill acquisition model that I think I've learned is if you somehow get yourself locked in this analytical way of looking at your skill, and if you don't realize that ultimately true expertise is represented by passing beyond this analytical skill into a discriminating and responding to situation skill based on experience, you'll never get really good. And what we found, I believe, in nursing also is the same phenomenon. Nurses who burn out are frequently nurses who find the job harder and harder because they never take the step from the more and more difficult analytical analysis of situations to pattern recognition. They fail to learn from experience. They fail to get involved in the situation and simply let the situation evoke the right response. And so, in summary, the characteristics that begin to emerge when a performer becomes proficient are, one, the performer begins to see changing relevances in the situation. And I want to emphasize the word see. It isn't that the performer figures out what the changing relevance is, but they simply see it based on experience. They have an increased sense of what's salient in the situation. Again, they don't have an increased ability to figure out what's salient. They simply have a sense based on experience of what's salient. As I've indicated, they have the increased ability to recognize patterns and respond to patterns based on previous experience, and they're involved in the situation. They're attuned to the situation. They don't see themselves in a detached way manipulating the situation, but simply they respond based on seeing changing relevance and discriminating distinct patterns.
In this vignette, we saw the nurse actively figuring out what was going on with the patient, which is very typical of the competent levels, is figuring out. While the proficient level is a dramatic leap from that. It's where the nurse simply notices and understands immediately what the problem is.
Whereas the new graduate suffers from a problem and an inability to recognize situations, The proficient nurse is much more engaged in the situation, and they also have a sense of when they have a good grasp of the situation or when they are chasing a problem or don't have a good grasp of the situation. They also have a nice sense of salience. Things just stand out for them as more or less important. They don't really have to figure all of that out. Now, this budding sense of salience, not infallible, but it's a real advance over the undifferentiated worry and nebulous feeling that something important might be missed that the new graduate has. Mastering new technology and techniques is essential for rapidly changing fields such as nursing, but a mere adding on and counting techniques and technology does not make expert judgment or expert performance.
Now, we saw a little bit of expert practice in the first vignette, so let's take up that story where we left off. The nurse in that situation was able to manage rapidly changing situations and still remain very engaged with the patient and the family.
We worked for several hours, but he didn't respond as we had hoped. Finally, the wife said, "It's time to stop," so we just stopped.
It's time to let go.
At that point, we knew this man would die within a few hours. As things quieted down, this peaceful look came over his face. It was really an amazing transition. Everybody was in the room, and it was much different dealing with the family. I could see them, and I could pay more attention to them, and kind of interpret for them what had happened. And the granddaughter had a lot of questions, particularly about the machinery and equipment.
What does that do?
The granddaughter gave the rest of the family an opening to ask questions, and she was so curious, so the adults followed suit.
How long? I'm not sure. Soon.
How are you doing?
I'm doing okay.
Good. I'm just going to take him this blanket.
Yeah, I'm going to get rid of some of the equipment.
Okay.
Thanks a lot.
Sure.
I felt a great urgency to get all the peripheral junk out of the room. And then I just let the family alone for maybe half-hour periods at a time, and I kept an ear out just to see how they were doing. After about 2 hours, the family started talking about him, reminiscing, not quite in the past, but yeah, I think they were working through some of their grief, and they were laughing a little bit too.
Remember that trip we took to Mexico? Where we had that awful breakfast in that cafe in Mazatlan? And he insisted that it was exactly the kind of place he wanted to be.
He died about 2 hours later.
As we've seen, expert nurses have mastered not only the technological complexity and the physiological complexity of a situation, but also the skills of patient and family involvement. The expert has learned how to make a wide variety of patients with a wide range of clinical conditions feel safe and cared for in this very alien and frightening environment. She grasps the situation as a whole. She's able to move in and smoothly coordinate practical caring measures to the high-tech interventions and the skill of involvement. We saw how she was with the family, that she made a space for the family to be with the patient, to be alone with the patient, while she stayed across the way with an ear out for what was going on, so that she was still quite accessible for the family. She was at home in this highly complex environment, yet she recognized what this must be like for the family. She could see the questions coming from the granddaughter and recognized the concerns that the family had about the equipment and so on, sought to get the equipment out of the room to make it a much more comfortable and domestic kind of environment for the family to be together with the patient as he died. Okay, we also see here that with this immediate grasp of the situations, that experts aren't making decisions based on rules, theories, or facts as we might see in the beginner practice. But instead, they base their judgments on strong evaluations and qualitative distinctions.
The concept of qualitative distinctions adds something to the discussion of the acquisition of expertise in nursing. I think when you look at the narratives and the practice of expert nurses, one of the things that's most striking is the way in which they're always making judgments about the situation of their patients. And this is in striking contrast, for example, to what happens with beginning nurses. If you think back to the vignette of the beginning nurse, the patient, the baby, really wasn't in the picture. She was very concerned about what was happening with the baby, but all of her concern was focused on the monitors, on things, as she said, like the fluid levels and the baby's heart rate and so on. And to know what was going on with the baby meant consulting the monitors and having knowledge, as she said, about what was going on, objective knowledge, knowledge that's available to any observer who looks at the monitor. I think what you see as nurses gain expertise, and particularly as they become expert nurses, is much more reliance on their own judgments of the situation. But through working with many patients, they've come to have a set of fine discriminations about what it means for a patient to be comfortable. And through working with a particular patient, they know what it means for that particular patient to be comfortable. So that what seems to happen is a great deal of fine-tuning and calibration in order to understand where a particular patient fits among the many patients whom a nurse has seen. And her interventions tend to be based on those kinds of judgments rather than on reliance on some sorts of objective science.
The study of expert practice necessarily leads to an investigation of ethical expertise. Because nurses stand where they do in the moral community, they help a family to hear the issues and confront painful decisions. Skilled, ethical comportment and astute judgment are essential to foster hope and courage where possibility for recovery exists, and courage and dignity when recovery is not possible.
Well, what's been striking to me as a clinician and a teacher about this work is its resonance for clinical nurses. Bedside nurses begin to recognize their practice and the narratives, and they begin to see their practice in a new way. They discover their practice for itself as a source of knowledge, and they realize that it's not merely subjective and idiosyncratic, that it's useful knowledge that they can communicate to other nurses. Well, new possibilities begin to show up, and some nurses for the first time are able to talk about or discover the very real knowledge, the practical knowledge in their practices. Much of the nursing practice is socially invisible. For example, the complications that we prevent every day from the rapid interventions that we make. Another example is the simultaneous interventions that we make with the multiple complex therapies that we implement, and then the suffering that we share with families. So the work is profound and necessary, and I think this research really makes nursing practice visible.